Hi everyone, it's Stacy Kiltz, one of the freshman faculty. I'm also a certified maternal newborn nurse, so I'm excited for this voiceover on newborn adaptation and assessment. The first 2 days of life is the neonatal phase. After 2 days of life until 1 month of life, it's called the newborn phase. And then from 1 month to 1 year is the infant phase. During this voiceover, we are going to review the neonate's transition to extrauterine life. There are many changes that have to happen for a successful transition from fetal to neonatal life. There are major respiratory changes that occur, as well as cardiovascular changes. Thermal regulation needs for the neonate are going to be discussed. Also, the hematological adaptations that have to occur. Then we will cover the newborn assessment and the diagnostic screening that's done on neonates, newborns, prior to hospital discharge. Lastly, the voiceover will cover a few of the more common complications of the newborn neonatal period. The establishment of extrauterine respirations is the most critical and immediate physiological change that occurs in the transition from fetus to neonate. To understand the initial respirations, let's go back and look at the in utero development of the lungs. When the alveoli began forming, they would produce what is called fetal lung fluid. This fluid will fill the alveoli and remain there through the gestation. As the fetus nears term, the production of the fetal lung fluid starts to decrease, and the fluid is going to move into the interstitial spaces. During the labor process, the absorption rate of the fetal lung fluid is going to increase, and it will continue to move out of the alveoli after birth and into the very early postpartum period. So surfactant is a slippery combination of lipoproteins that starts developing around 24 weeks gestation. And it's very important because it decreases the surface tension within the alveoli. Without it, the alveoli collapse when the newborn goes to exhale. Usually around 34 to 36 weeks gestation, sufficient surfactant will be produced, and this will prevent the infant from having any respiratory distress at birth. So if a woman goes into labor and it's preterm, she'll usually get some steroid injections because this will increase the production of surfactant and aid in the lung maturation. Any of the remaining fetal lung fluid left over at birth is also going to be forced out of the alveoli and into the interstitial spaces by the newborn's first breaths, and then it'll allow air to enter the lungs. The initiation of the first breath is going to be stimulated by several factors: chemical, mechanical, thermal, and sensory. The chemical factors refer to the chemoreceptors in the carotid arteries and the aorta, and they're going to respond to any decreased oxygen in the blood. The mechanical factors occur with delivery. This is when the fetal chest is compressed by the narrow birth canal. That is going to aid in forcing out any extra fetal lung fluid from the alveoli. And once that pressure in the chest is relieved at birth, it will draw a small amount of air into the lungs, and it reduces the amount of negative pressure needed for the first breath. The thermal factors are changes in temperature from the birth canal to the outside air. This is going to send messages from the skin to the respiratory center to stimulate the brain to breathe. Lastly, the sensory factor is going to occur during the tactile stimulation of birth. This is when the physician's handling the baby as it comes out of the birth canal, and as the nurse dries and holds the baby and then places the infant skin to skin. All of these factors combined allow that neonate to take that successful first breath. Cardiovascular adaptation involves the transition from fetal to neonatal circulation. During fetal life, there are 3 shunts in the fetal system that are functioning: the ductus venosus, the ductus arteriosus, and the foramen ovale. At birth, these 3 shunts close with the initiation of breathing. This happens because of changes in the blood oxygen level and shifts in the pressure in both the heart and lungs from the first breaths and the clamping of the umbilical cord. I teased apart the figure from your textbook so that you could see the processes involved in the closure of each of those shunts. Thermoregulation was unnecessary during fetal life, since maternal body temperature would regulate the temperature of the fetus. But once born, the neonate must be able to produce and maintain their own heat to prevent the serious effects of cold stress. As the nurse, one of your jobs will be to maintain a neutral thermal environment for the neonate. A neutral thermal environment is an environment that maintains body temperature with minimal metabolic changes and or oxygen consumption. Neonates are predisposed to heat loss for a couple of reasons. The first is that their skin is very thin. Then the blood vessels are close to the surface of the skin, and they have little subcutaneous fat to provide a barrier to heat loss. There are 4 primary methods to heat loss in neonates. The first one is evaporation. This is when the air drying the skin results in cooling. This is why it's really important for the nurse to immediately dry the neonate after birth and apply a hat. Conduction is the movement of heat away from the body to an object that is cooler than the skin. So this is why any object that has to touch the neonate should be warmed up first. And if they have to go on a scale or radiant warmer, they should be warmed, or some sort of barrier, paper barrier, towel barrier, be used between the scale and the neonate. Convection is the loss of heat from air. This can happen if there's a draft or air conditioning or the door is open. So it's any kind of circulation that's colder than the body temperature. Finally, there's radiation. This is heat loss from the neonate from being next to a cold surface. So if the isolate walls, for example, are very cold, if the infant is close to the walls, it will reduce if the neonate is close to the cold isolate walls, their temperature, if the infant is close to the cold isolate wall, if the neonate is close to the isolate wall, if the neonate is close to the cold isolate walls, that will reduce the neonate's heat through radiation.
Now that we've talked about thermoregulation, let's talk about thermogenesis. When the newborns are cold, they start to become restless and cry. This in turn increases their activity, increases their muscle flexion, the increased metabolism, and some vasoconstriction because of the encounters with the cold will create some heat, but the primary method for heat production is going to be non-shivering thermogenesis. This is the metabolism of brown fat to produce heat. Brown fat is the adipose tissue that's present in newborns and infants to metabolize for heat. It's important to understand that a preterm newborn or a small for gestational age newborn are going to have less brown fat stores than a full-term newborn. So all of these factors combined are going to increase oxygen and glucose consumption and makes the newborn more likely to develop respiratory distress, hypoglycemia, and jaundice when thermogenesis is needed frequently. So the ideal situation is to keep that neutral thermal environment so that the infant stays warm without having to rely on the brown fat non-shivering thermogenesis to create its own heat. Because creating its own heat could lead to these potential problems because the infant is depleting its own resources. So as you can see from this list on the slide, cold stress, when the infant is challenged to meet its heat needs, is something to take seriously in the newborn. Cold stress is a term that describes excessive heat loss that leads to hypothermia and results in the utilization of compensatory mechanisms to maintain the neonate's body temperature. Cold stress causes an increase in the metabolic rate, and it will increase the metabolism of brown fat. This will cause a significant rise in the newborn's need for oxygen. So it's not unlikely that the infant will develop the respiratory distress because of the increased need for oxygen. It's also going to diminish the production of surfactant. Glucose is going to be needed in great amounts. So when the glycogen stores are converted to glucose, they can be quickly depleted, resulting in hypoglycemia. It's also important to note that when non-shivering thermogenesis occurs, it will release fatty acids into the system, which can cause metabolic acidosis, and this can be life-threatening in the newborn. Another thing you'll see is that elevated fatty acids in the blood can interfere with the transportation of bilirubin to the liver, which is how we rid the body of bilirubin. So the newborn's risk for jaundice also increases with the cold stress. There are a lot of hematologic adaptations going on in the neonate right after birth as well. First, the erythrocytes, hemoglobin, and hematocrit are elevated, and this is because there is less oxygen available in fetal life than after birth. Leukocytes, the white blood cells, are often elevated right after delivery. This does not necessarily indicate an infection. Actually, often in sepsis in neonates, the white blood cells are decreased. The white blood cells will normalize by about 4 to 5 days of life. With clotting, you want to remember that in adults, vitamin K is synthesized by our gut flora in our intestines. Because neonates are born with a sterile gut, they have a lower level of vitamin K at birth and can't clot their blood as well. Therefore, vitamin K is necessary, and this is why we administer it after birth intramuscularly. In New York State, this is a requirement, and it cannot be declined by a parent. Blood glucose monitoring is done fairly regularly in the newborn nursery because glucose is used rapidly during the stress of delivery and also used for breathing and heat production after birth. So until neonatal feedings are adequate, glucose will be used from the body. The glucose threshold for a neonate is between 40 to 60 milligrams per deciliter for day 1 of life, and then it should go up to 50 to 90 milligrams per deciliter for day 2 and after. Some newborns are going to be at a higher risk for hypoglycemia. These are the preterm or late preterm newborns, late preterm being defined as between 36 and 37 weeks gestation, small and large for gestational age, those in neonates born to diabetic moms, and those exposed to excessive stressors. These infants should be monitored closely for signs and symptoms of hypoglycemia, such as jitteriness, poor muscle tone, etc. They also are usually on some form of glucose monitoring per protocol at any facility. Hyperbilirubinemia means high levels of bilirubin in the blood. The liver is the main organ involved in conjugating bilirubin for excretion from the body, and a neonate has an immature liver at birth, so it may not be able to prevent jaundice, which is yellowing of the skin, that's going to occur when there is excessive bilirubin built up in the blood. There are different types of jaundice. Physiologic or non-pathologic jaundice is not usually present on the first day of life, not usually a cause of concern because it's usually transient and considered normal because the bilirubin is going to go up a little bit but not to a dangerous level. Another form of jaundice is pathological jaundice, and it is present in the first 24 hours of life, and it's usually the result of an abnormality. This can be a blood incompatibility between the mother and newborn blood types, or it can be from an infection or a metabolic problem. This type of jaundice usually needs to be treated with phototherapy and can prolong a newborn's hospital stay. Then there's breast milk jaundice, caused from insufficient production of breast milk, which occurs after the first few days of life. Remember, bilirubin is excreted through the stool. So if the newborn is not stooling frequently enough because of reduced breast milk intake, they are going to hold on to more bilirubin. The graph on the slide is similar to what is used in many facilities. Most facilities follow guidelines from the American Academy of Pediatrics, which determines what kind of intervention is necessary dependent on the bilirubin levels of the newborn at specific time of life. These decisions or treatment options range from simply following the infant visually or using serial bilirubin levels from the blood to treatment with extensive phototherapy and possibly even exchange transfusions if the levels are severely high, because severe levels of jaundice can cause kernicterus, which can cause permanent brain injury.
The nurse's role immediately after birth is to support the newborn's cardiopulmonary and thermoregulatory transition. Only 1% of neonates need extensive resuscitation at birth. However, each birth should be attended by a nurse solely dedicated to the care of the infant, who can initiate resuscitation measures if needed. The delivery room should be prepared for the newborn with all the resuscitation equipment and have a preheated radiant warmer with warm blankets. Most newborns only require simple and gentle stimulation to take the first breath. Their mouth and nose is usually bulb suctioned by the healthcare provider as the head emerges. Once the rest of the body is delivered, the baby is either placed skin to skin with the mother or placed in a radiant warmer. The next step, drying the newborn with the warm blankets, will usually provide sufficient stimulation for the neonate to breathe and cry if it hasn't already done so. If the neonate needs more intensive intervention, including the use of oxygen, positive pressure ventilation, or chest compressions, it will need to be in a radiant warmer. The nurse will assign APGAR scores at 1 and 5 minutes after birth. The APGAR score is a rapid assessment tool for reporting the status of the newborn as it transitions to extrauterine life. Muscle tone, pulse, grimace, skin color, and respiration are assessed and scored. A score of 7 or greater indicates that the newborn is stable and just needs continued observation. A neonate with a score less than 7 will need some level of resuscitation. I included the APGAR scoring system on the next slide so you can review that. and there is also a link to practice questions on determining APGAR scores embedded on the screen. The stable newborn can remain on the mother's chest for skin-to-skin contact, ideally for 60 minutes. The nurse would place a hat on the baby's head and place dry, warm blankets over the baby and mom for warmth. Vital signs will be monitored per facility policy, typically every 30 minutes in the first 1 to 2 hours. The neonate will also be quickly assessed by the nurse for any obvious signs of abnormalities. Neonates experience predictable behavior during the first 6 to 8 hours after birth, referred to as periods of reactivity. The initial period of reactivity occurs immediately after birth and lasts about 30 minutes. The neonate is alert, active, and responsive to stimuli. This is a great time to initiate breastfeeding. The period of relative inactivity follows and lasts about 2 hours. During this time, the neonate enters a sleep state and becomes unresponsive to external stimuli, including attempts to feed. Finally, the second state of reactivity follows and varies in length from 2 to 8 hours. Much of this time, the neonate is in the awake or quiet awake states, another excellent time for breastfeeding. Neonates will typically receive 2 medications during these first few hours. Erythromycin ointment is applied to both eyes as prophylaxis against any vaginal canal bacteria that might have come in contact with the newborn's eyes. And an injection of vitamin K is given intramuscularly to help boost the neonate's blood clotting abilities to prevent potentially life-threatening bleeding. Finally, the mother and newborn are going to be properly identified before any potential separation occurs. This is usually done with footprints from the baby and a fingerprint from the mother. Then identification bands with the mother's name and infant sex, date and time of birth, and medical record are also applied to mom, baby, and a third person, typically the father, or another support person who's going to be with the mother. This identifies the mother and the other caregiver as the only people who can be alone with the neonate. And if the baby is taken from the mother's room for any reason, staff are responsible for checking that the ID band on the baby matches the ID band on the infant when returning the infant to the room. Only certain staff members with special insignia on their ID tags can transport newborns in hospitals. As student nurses, you would never remove a baby from a mother's presence. Before we go through the head-to-toe assessment, let's look at some normal vital signs for a neonate or newborn and normal intake and output. So the axillary temperature for a neonate should remain in the 97.7 to 99 Fahrenheit or 36.5 to 37.2 degrees Celsius range. The apical pulse is usually 110 to 160 beats per minute, but it can go as low as 90 in sleeping or as high as 80 if the infant's crying. Respirations are usually 30 to 60 breaths per minute, but not consistent regular respirations like that of an adult. These are respirations that will be periodic, sometimes quicker than others, sometimes small pauses. For the first 2 days of life, the stool of an infant is going to be meconium, which is a black to greenish black tar-like substance that passes. And then you will have transitional stool, which is moving from the greenish black to a greenish brown until you get to yellow stools, which will be semi-formed for the breastfed infant and more formed and a little bit browner for formula-fed babies. Infants should also be urinating at least 6 times a day by day 4 of life. As I mentioned earlier, right after birth, there is a quick assessment of the neonate for any obvious signs of abnormalities. Later, a thorough head-to-toe assessment will be done. Molding of the head is normal after birth, and it may cause the head to appear misshapen. The fetal head passes through the narrow birth canal because the sutures, which are soft junctions between adjacent skull bones, allow for some movement of the bones so the fetus can fit through that tight spot. The fontanelles are where the sutures of the head meet anteriorly and posteriorly. If the molding isn't too severe, you should be able to palpate both the anterior and posterior fontanelle. The anterior fontanelle is diamond-shaped, while the posterior fontanelle is triangular. They should both feel full. Any sunken or depressed fontanelles could indicate dehydration. A bulging fontanelle is common when the baby is crying, but if it's continually present, it could indicate increased intracranial pressure. Sometimes the skull bones actually meet, and you will palpate ridges where the suture should be. This is called overriding sutures. The picture on the top left displays caput succedanum, which is localized swelling caused by pressure against the cervix. It crosses the suture lines. The picture on the bottom left is a cephalohematoma. This is the result of bleeding between the periosteum and the bone. It can occur during a delivery, especially when there's use of forceps or a vacuum. Neonates with a cephalohematoma are going to be at higher risk for jaundice, since the body is going to need to break down those red blood cells with an immature liver. You want to assess the face for symmetry and the position of facial features. In the picture on the bottom right-hand side of your slide, you can see the difference between normal ear location and low-set ears. Low-set ears could be a sign of fetal alcohol syndrome or a congenital abnormality. You may also find skin tags or small pits near the tragus of the ear. The sclera of the eye should be white. Edema of the eyelids and subconjunctival hemorrhages might be present. They result from pressure on the head during the birth and usually resolve spontaneously. You want to assess the nose to make sure both nares are patent. Neonates are obligatory nose breathers, which means they only know how to breathe through their nose, not their mouth. Anything obstructing the nose can cause respiratory distress. The mouth can be assessed and the sucking reflex checked by placing a gloved finger in the neonate's mouth. The infant should suck on your finger, and while this is happening, you should feel the roof of the mouth, the hard palate, for any holes which would indicate cleft palate. The neurologic system of the newborn will be assessed primarily through the presence, strength, and symmetry of the reflexes. Any diminished reflex could indicate illness, and the absence of a reflex can indicate a serious neurological problem. Your book has several wonderful pages on reflexes to review. You need to be familiar with these reflexes, how they are elicited, and what a normal or abnormal response is. I put the page numbers on your slide. Assess the ears for open canals. The state mandatory hearing screening will be done prior to the newborn's discharge from the hospital. Other neurological signs to assess for are tremors and jitteriness. These could indicate hypoglycemia, hypocalcemia, or drug exposure in utero. Seizures could indicate a central nervous system or metabolic abnormality. The neonate's cry should be assessed. A shrill, high-pitched cry could indicate neurological disorders or other problems. Excessive irritability could also indicate neurological system injury or opiate withdrawal. When assessing a newborn's neck, you want to make sure that they can turn their head side to side easily. Assess the clavicles for lumps, swelling, or crepitus on palpation. These could indicate injury to the brachial plexus or a clavicle fracture that might have occurred during birth. The umbilical cord should contain 3 vessels, 2 arteries and 1 vein, and should remain clamped until it's completely dry. There shouldn't be any redness or drainage from the base of the umbilical cord after delivery. If there is, the pediatrician should be notified. The extremities of the newborn should all move actively and equally in a random manner. They should remain flexed. If not, this would indicate poor muscle tone and could be an indication of a respiratory or neurological dysfunction, or possibly hypoglycemia. Then assess the hips for hip dysplasia, which can be felt either when abducting or adducting the hips. Usually a clink or clunk will be felt or heard when moving the hips if dysplasia is present. Now let's assess the integumentary system. It's important to note that any marks on the skin should be documented, including the size, location, and general description. Make sure to explain any marks to the parents and offer emotional support if they get upset. The color of the skin should be pink or tan. Any jaundice assessed by blanching the skin over the nose or sternum is abnormal and should be reported to the healthcare provider immediately. Vernix is the thick white substance that resembles cream cheese that protects the fetal skin in utero. It's more common in preterm newborns than in term newborns, but can still sometimes be found in the creases of the groin, armpit, and neck of the neonate. Lanugo is the fine soft hair that covers the fetus in utero. Milia are white cysts that cover the nose and chin sometimes and resemble acne. They typically disappear within the first week without any treatment. Erythema toxicum is newborn rash. It is white or yellow papules or vesicles. They usually have a red base. It can appear anywhere on the body. It looks uncomfortable, but it does not bother the neonate. The cause is unknown, but it usually resolves within the first 3 months of life. There are a number of birthmarks that you can find on neonates. Your book describes the various types on the pages you see on the slide. The birthmark size, location, color, elevation, and texture should all be carefully documented. Any marks that occur from delivery should also be documented, and they include bruising or petechiae, puncture marks from a fetal scalp electrode, and forceps or vacuum marks on the head. Finally, the last assessment that is sometimes done is a gestational age assessment. The new Ballard Maturational Assessment Score is typically used if the mother didn't have any prenatal care or if the provider wasn't sure of the due date. It uses the muscular, skeletal, and physical characteristics described on the slide to identify the approximate age of the newborn. The textbook describes how each characteristic is assessed on the pages noted on the slide. I have also inserted a link to a video with the briefest explanation of Ballard scoring I could find on YouTube. It walks through an actual Ballard assessment of a preterm infant. You can watch it if you like. This assessment is typically done more frequently on preterm or NICU babies. So neonates undergo a lot of testing while they are in the hospital. Some of it's mandatory, some of it's elective. In regards to testing, all states have a newborn screening program that tests for metabolic and genetic disorders by gathering a heel stick blood sample from the neonate placed on specific PCR paper that is then sent to the state labs for processing. Most states also mandate hearing screenings, which we talked about already, and critical congenital heart defect screening, which is basically placing pulse oximetries on a newborn's wrist and an ankle simultaneously and checking the readings. For the newborn to pass, the scores need to be 95% or greater on both limbs, and the two scores cannot be more than 3 points apart. We've talked about hyperbilirubinemia. Most facilities now will do a bilirubin blood test, although there are transcutaneous bilirubin monitors on the market which use a light bounced against the skin to determine the bilirubin level. Blood type in Coombs testing is done usually off of cord blood, but that's done for the infants of mothers who are negative blood type to determine whether the mother needs to receive more RhoGAM. It's also done sometimes when there's hyperbilirubinemia to eliminate any blood incompatibility as an issue or cause of the jaundice. So besides for these blood draws, newborn males are sometimes circumcised, and that's an elective procedure decided upon by the parents and done by the obstetrician while the infant is hospitalized, or in certain religious circumstances done outside of the hospital. Pain management should be provided for every neonate whenever they're undergoing any type of uncomfortable testing or procedure. Non-pharmacologic methods include swaddling the infant tight, holding the infant, and non-nutritive sucking, which is having the neonate suck on a pacifier or a gloved finger. Pharmacologically, we have the availability of sucrose solution, which is sugar water. Topical lidocaine can numb an area before a procedure, and acetaminophen or Tylenol can be given to neonates post-procedure for 24 hours as well.
In terms of newborn complications, hypoglycemia and hyperbilirubinemia have been covered already in this voiceover. Phenylketonuria, or PKU, is an inborn error of metabolism. Neonates with PKU are unable to metabolize phenylalanine, an amino acid commonly found in foods, including breast milk. Brain damage and death can occur from the buildup of metabolites of phenylalanine. This is one of the disorders checked for in the mandatory newborn screening program. Early detection and dietary modifications are key to managing the condition. Preterm infants are those infants born before 36 completed weeks of gestation. Prematurity and low birth weight are the second leading cause of infant death in the United States, after congenital malformations and chromosomal anomalies. There are many factors that place a woman at risk for preterm labor. Some can be modified, others cannot. A table outlining these risk factors is found in your text on the page noted. The more premature the newborn, the higher the chance of complications and possibly death. Premature newborns can have respiratory issues due to immature lungs and the use of mechanical ventilation. They lack the ability to coordinate sucking and swallowing, and therefore often have feeding difficulties. With less body fat, preterm infants will need support maintaining their temperature. Most preterm infants born before 36 weeks are cared for in specialized neonatal intensive care units, or NICUs. Substance abuse puts neonates at risk for withdrawal at birth. Neonatal abstinence syndrome, or NAS, is a group of signs and neurological behaviors exhibited by neonates resulting from the abrupt discontinuation of intrauterine exposure to various substances, including heroin, nicotine, alcohol, marijuana, opiates, cocaine, and methamphetamines. The severity and timing of the withdrawal is related to the last maternal use of the substance and the type of substance and its half-life. There are numerous possible signs and symptoms of neonatal withdrawal. Several screening tools are available to monitor newborns experiencing NAS. Nursing care is mainly supportive. It revolves around managing symptoms and providing a calm, quiet, darkened environment to decrease stimulation. Newborns who experience a higher magnitude of withdrawal need to be treated with medication and are typically in NICU.